Okay, let's get started. Thanks for joining us again as we come to near the end of this particular cardio series. Again, a reminder, no PHI, please, in descriptions of your cases or other patients. This morning, we have two interesting cases from Austin and Brittany, and Chris is going to talk to us about dietary guidelines, and Chris and I will discuss the two cases from different perspectives. Next slide. Some information about any assistance you might need. Next slide. And these are our disclosure statements. I don't believe there were any changes from the prior week. Reminder again to avoid language that may be considered offensive, and please use patient-centered language throughout. Next slide. And Chris, please take it away.
Great. Thank you, everyone, and welcome back for another week for ECHO. This morning, I'm going to speak to the dietary guidelines kind of broadly and also more specifically around our US dietary guidelines. So kind of talking about the contents, how they're kind of very similar, different, and how we can put them into place with our patients. So the objectives describe sources of dietary guidelines, recent changes, and approaches for incorporating them into daily counseling. So what I wanted to start with the more broad focus is a lot of the questions that we get is, does the US really have like one nutrition or one health set of guidance? And because the government is spread and the health is spread across so many different avenues of the government itself, the dietary guidelines represent a culmination of all of Health and Human Services and USDA coming together to create kind of a centralized recommendation for what is healthy eating in the US. So the latest release of the dietary guidelines came out in 2020. So it's now the 2020 to 2025 dietary guidelines. And they're really set up every 5 years and updated with the science every 5 years to give us what our latest recommendations are around healthy eating and healthy eating patterns. So this is federally mandated that they are updated every 5 years. So the next release will then be the 25 to 2030 dietary guidelines. And the process that is used is to really evaluate not just kind of current recommendations, but to really delve into the science and look at the evolving nature of our dietary recommendations. What is the evidence on these health outcomes? And then how do these get translated into healthy eating recommendations? And one of the things that's probably less appreciated from the dietary guidelines is the trickle-down effect that's used for what these nutrition recommendations are as to within all of different federal nutrition programs. So these dietary guidelines set the standard for WIC programs, the Women, Infants, and Children, for the school lunch program. So a lot of the federal programs that provide food use the dietary guidelines as a way to shape the appropriateness of and the completeness of the foods and the meals being provided. So from a broader sense, sources of dietary guidance that we have from kind of a daily perspective, we have this foundational US dietary guidelines that is really established to set the guidelines for the healthy population in the US. But to go along with these, we have several specific recommendations that come from professional associations. The American Heart Association has a particular subcommittee that addresses nutrition components in addressing, preventing, and treating heart disease. The American Diabetes Association develops nutrition recommendations as well. And with that particular bent, the guidance that they're going to develop is going to be more specific to the disease state in which they're representing. So the American Cancer Institute is going to have very specific guidance around cancer prevention, cancer treatment, survivorship. So you'll see many of the same tenets that happen in the US dietary guidelines, many of those same fundamental recommendations. But the American Heart Association is going to be more focused on saturated fat, added sugars, and sodium in comparison to what you might see with the American Diabetes Association. That's going to be a little bit more focused on carbohydrate carbohydrate intake, balancing carbohydrate intake, and other related factors, added sugar. So we see a general theme overall with a lot of our dietary recommendations that we have a broader picture around what healthier eating is. And then the professional associations are mainly taking a look at a specific element to help improve those specific outcomes. And then we see this at a broader level on the dietary patterns, the DASH diet, the Mediterranean diet, too, for example, related specifically to some overall kind of dietary patterns to promote certain foods that promote health, to limit foods that have a negative impact on health. But if you really look down through the entire list of these, the fundamental threads that run through each one of these: increasing fruit and vegetable consumption, increasing whole grain, reducing refined grain, limiting added sugars, limiting saturated fat. There really is a consistent message that falls throughout all of these dietary recommendations. So sometimes it gets a little overwhelming. Think about which one should I look at, which one should I use, which is the more appropriate. Many of them have much this same thread that runs all the way through in terms of a consistent message around healthy eating. And then I want to add the other category at the end, which one of my comments that I always make to the students in class is you can't sell a diet book using moderation. No one gets excited about don't eat too much and eat your fruits and vegetables and eat your whole grains. Those don't sell books. Those don't sell programs. So we have a lot of other dietary guidance that starts to fall to this outside of this usual pattern. So in the dietary guidelines, they looked at intermittent fasting and basically made the indication that for weight management, there wasn't enough evidence for intermittent fasting as a way to promote weight management and as a healthy eating pattern. So as we start looking at the overall dietary guidance, and the patients will come in asking about, well, I read about this one, and what about this diet? We'll be looking more at how does it address overall eating patterns? How is it looking at energy needs that an individual has? And really kind of using our higher list here of what these overall dietary recommendations are as to how we can help them best make their decisions. So quickly, what I wanted to do was just illuminate the process that the dietary guidelines goes through. And they're in the current process now at about stage between 2 and 3. With some recent controversies that have occurred around developing questions, the process has changed that they get federal takes public comment on the scientific questions to help shape what the questions will be that'll be assessed for the Dietary Guidelines Advisory Committee. So they've created the list of questions that are going to be tackled from the evidence standpoint. Then nominations will be submitted for experts, the 20 experts that will make up the advisory committee that will review the evidence. They're reviewing nominations now and will make the appointments hypothetically in January of 23. And then the group will take on reviewing the scientific evidence, looking to see what's new since the last 5 years, and really conducting the systematic review, but also this food patterns modeling approach where they take the National Health and Nutrition Examination, or NHANES data that's collected, and really look at what those dietary patterns are, what is the consumption that we have, and what are those implications for the total nutrient profile, and not just meeting calories or eating enough fruit and vegetable. And then that scientific evidence is summarized into the massive scientific advisory committee report. And then that scientific document is then passed off to USDA and Health and Human Services to create the document that we see on the more on the consumer end, that is the dietary guidelines for Americans. So if you are looking for a source of the updated literature on saturated fat and the outcomes for health outcomes, you can go to the American Heart Association's review, and you can also look at the scientific advisory report for the dietary guidelines if you're really trying to get caught up on some of the more recent evidence around, say, saturated fat. So just the kind of quick visual to demonstrate the process is that the scientific evidence is generated on the left-hand side into this committee report that really gives us this translation of this, or this summary of the scientific evidence around healthy eating. And then on the right-hand side, on the light blue, is how the dietary guidelines are actually developed to meet that audience for policymakers, for health professionals, and for the public. So the science is developed on the left side, and on the right-hand side is the information that we can use to help patients make better choices. So the main summary of the overarching guidelines that the dietary guidelines has produced for the 2020 to 2025 to follow a healthy diet pattern for every stage of life. A lot of the 2020 dietary guidelines really focused on, this is the first time they created recommendations for under 2 years of age. So there's a heavy portion of the dietary guidelines in there, but they've taken a bigger step towards expanding this towards life stage types of concerns. Customize and enjoy nutrient-dense food and beverages to reflect personal preferences, cultural traditions, and budgetary considerations. So this is really getting to the level of personalizing the recommendations to the needs of the individual and the actual individual themselves. And the other thing that has really begun to emerge, especially in a lot of the dietary recommendations over the past, I say, decade or so, is to really focus more on meeting foods and food groups and overall healthier choices rather than addressing individual nutrients and focusing on getting kind of myopic on just added sugars or just saturated fat, but looking at a broader overall healthy eating pattern. So many of you have probably seen MyPlate in the past. MyPlate is basically what the Center for Nutrition Policy and Promotion creates to take all of the evidence and try and turn it into a visual that can be used for educational materials for the public. I think we probably all remember the food guide pyramid that had the tip with the fat, sweets, and oils and the grains at the bottom. It was one of the first major efforts to create this visual for dietary patterns. And people got confused by the pyramid, but what they did determine was 80% of people recognized that that pyramid meant something about healthy eating. So it's this use of visuals that really help people translate these overall recommendations into what the daily pattern is. So in the MyPlate here, it's really this emphasis on fruits and vegetables, that if half of your plate is fruits and vegetables and grain, and then about a quarter is grains, it really demonstrates what Dr. Werner was talking about previously around promoting this plant-based diet approach. So this is a visual depiction that now helps people make translated onto their plate themselves this recommendation, increasing variety, increasing color, increasing the contribution of plant-based foods to the diet. So to kind of bring this around full circle, a lot of these guidelines focus on lifestyle behaviors with lifestyle behaviors balanced with pharmacologic therapy. So a lot of our discussions have been looking at medications versus lifestyle behavior change, and how do we present both of those as an option. A lot of times patients will perceive medications to be the solution to their diabetes, to their heart disease. I need a medication, and as long as I'm taking my statin, I don't need to change my diet because that's what I'm taking a statin for. So really trying to emphasize together the fact that the lifestyle becomes not just a secondary approach if other things aren't working, but to be a primary approach to minimize the need to rely on pharmacologic treatment, at least as heavily in many cases that we've seen. So many of the patients, especially in the work that we've done trying to link primary care patients to nutrition counseling with dietitians, they've basically told us, I knew lifestyle was something I should do, but it was never really something that I thought I had to do until my doctor told me, I think you should do this and take this considerably, because they told me all the time that I did, but I didn't realize how important it was until they actually made the referral for me to take action on it. So a lot of times the patients would be hesitant to actually even try and make changes until it became a priority set for them by their healthcare provider. So in translating these guidelines to food, the U.S. Preventive Services Task Force recommends moderate to high intensity counseling to really facilitate behavior change, which means we can have short conversations that will allow us to open the door to get the process started. But a 5-minute conversation about eat more fruits and vegetables and don't drink sugar sweetened beverages will not be enough to facilitate these larger meaningful lifestyle behavior changes. So we really want to be able to help the patients get access to counseling, whether it be we've talked about some of the community-based programs, diabetes prevention programs, referring to a dietitian, referring to a diabetes educator, any way that we can get them more intensive time to kind of look at their current situation and make these changes. And it really is going to require us to then translate these guidelines into their personal situations. We've talked a lot about individuals that have limited access to food or to community resources. So what are the ways that we can help them bridge those gaps to get from, I know you want me to eat more fruits and vegetables, but what do I have access to? How can I afford these? And really starting to focus on this idea of overarching, what are the foods that people are eating and the dietary behavior changes? Because we can say, I want you to eat less salt. But if their focus is on, if the only thing they're able to afford is canned food for their current environment, there are strategies that we can use to find lower sodium foods or behavioral elements like rinsing canned vegetables to help rinse out some of the salt. These are strategies that can be used to help identify how can we translate those nutrient recommendations or those changes that we want into actionable strategies. And finally, we are a team. We're a healthcare team. And many of these behavior change issues are really about addressing competing demands. It's time, it's money, it's knowledge, it's skills that they may need. So really looking to what are the available services that are available. We have many food assistance programs that will help with gaining access to food. But that also means many individuals are making choices between car payments, rent, medicine, and food. So being able to link them to other services that might be for housing assistance, might be some of the elements that you need to free up the income that they have to be able to access the food that they're looking for. So referrals for team-based care, thinking about the dietitian as a front line for providing that dietary counseling, the time to be able to understand their needs, what their challenges are, and help them create strategies. Addressing mental health concerns. We've talked a lot about these in our cases with anxiety and depression and other mental health concerns that have an impact not only on the individual's health status, but their motivation, their capabilities. And food assistance or life assistance programs, using the patient advocates that can help link the patients and help them navigate the systems that will get them access to other resources that will support their needs, helps free up not only some of the stressors in making these changes, but also open doors for access, affordability, etc. And really finding their why. Because we have a lot of particular reasons why we want them to make changes. We can see their lab values, we can see the medications, we can see the trajectories. Sometimes they can see those concerns, sometimes those concerns are less than other basic primal needs that they're trying to address. So how can we identify a strategy that takes away some of the stressors and some of those concerns and helps them find a motivating factor that will drive them to make changes? And it might be overcoming some other challenges, maybe isolation, then increasing activity with a friend or relatives or family might help increase some of those social situations, which then may also help with the lifestyle behavior, which then may facilitate them gaining confidence and being able to take on more behaviors. So with that, I will stop to take questions.
Thanks for that great presentation, Chris. Any questions for Chris? I had a question, and that deals with the impact of the dietary guidelines for Americans. And it's obviously it's unlikely that I'm going to sit down with a patient, go over the guidelines, and they're going to follow them. Obviously, very few do. But it seems like, is your impression the same as mine, that they seem to have an impact on policy, food policy, more so than on individuals? So schools in particular tend to follow the dietary guidelines when they put together their USDA approved lunch. Can you comment about that?
Yeah, and it does have a huge policy implication, because what it does is basically sets a standard. And the other nice part about this is that it's not just a standard for what foods should an individual consume, but they're looking at the dietary patterns, not only to meet the not only to meet the food recommendations and to kind of look at that overall, but underlying those food patterns are also making sure that they meet the nutrient recommendations. So when you create dietary guidelines that are used by school foods and adult congregate meal sites and those types of programs, not only are you creating a standard for the types of food to be set, but you're also helping support the nutritional recommendations, especially for those populations that age. So those guidelines really help with the dietary sufficiency, but also the nutritional sufficiency. This is one of those things that I've raised about many of the other weight management approaches, is that reduction in calories doesn't automatically translate into nutritional adequacy. So this picture of a broader dietary approach really hits that policy level to really address not only what types of foods, but also the nutritional gaps, especially around the nutrients and public health concern, that we have challenges. But at the same time, these educational materials are used within, so the Supplemental Nutrition Assistance Program, or SNAP, which used to be food stamps. The SNAP Ed program really focuses on these dietary guidelines educations. The Cooperative Extension Service, that's really through USDA, through the land-grant universities, is pushing the education out into the community focused on these dietary guidelines. So we're getting it from a grassroots education level side, but then also from a policy perspective to try and shape the food environment.
Great. Thank you, Chris. Any additional questions or comments? If there's no additional comments, let's turn things back to Claire for a moment here.
Sure. Rick, you can go on to the next page. So just a reminder that next week is Thanksgiving, so we will not be having clinic. Enjoy break, hopefully. And then we'll resume December 1st, and then we have 2 more weeks left. So the following week will be our last week. Your survey should be in your inbox. We appreciate your feedback. We're currently planning for our spring curriculum and are using your feedback directly. If you want to give any feedback that you've missed on previous weeks, I can resend it. If that is something you want to do, just reach out to me and I'm happy to do it. Otherwise, we'll see everybody December 1st.
Thanks, everyone. Have a good Thanksgiving. Take care.